Bypass tracts. Bypass tracts, or accessory pathways, are abnormal conduction tissue tracts that establish electrical connection between the atria and ventricles, other than the normal conduction system comprised of the atrioventricular node and the His-Purkinje system. Anatomic positions of bypass tracts. 1. Left free wall bypass tracts, around the mitral annulus, constitute about 50% of cases. 2. Inferoseptal bypass tracts, constitute about 25% of cases, either left inferoseptal, around the mitral annulus, or right inferoseptal, around the tricuspid annulus. 3. Right free wall bypass tracts, around the tricuspid annulus, constitute about 15% of cases. 4. Right anteroseptal bypass tracts, around the tricuspid annulus, constitute about 2% of cases, while other bypass tracts are present in about 8% of cases. This schematic shows the anatomic positions of bypass tracts. Either around the mitral annulus, left free wall, dark red, and left inferoseptal, light violet. Or around the tricuspid annulus, right inferoseptal, light violet, right free wall and right anteroseptal, light red. ECG manifestations of left free wall bypass tracts. Ventricular activation starts laterally near the bypass tract and spreads rightwards. Lead V1 consistently shows tall R wave, which may be followed by a small S wave. Delta waves are usually negative in one or more of the lateral leads, leads 1, AVL, V5, V6, but may be isoelectric or even positive, if pre-excitation is minimal. With significant pre-excitation, for example during atrial fibrillation, right frontal plane QRS axis deviation occurs, but may be normal during sinus rhythm, if pre-excitation is minimal. This schematic shows ECG with left free wall bypass tract. To the left, during sinus rhythm, tall R wave in V1 is seen, with normal QRS axis. To the right, during atrial fibrillation with full pre-excitation, right axis deviation occurs, while tall R in V1 persists. ECG manifestations of inferoseptal bypass tracts. Ventricular activation starts inferiorly, and spreads anteriorly. Leads 3 and AVF show negative delta waves. Lead V2 shows tall R waves. Lead V1 shows either tall R with small or deep S waves, suggesting a left inferoseptal bypass tract, or QS pattern suggesting a right inferoseptal bypass tract. This schematic shows ECG inferoseptal bypass tracts. Negative delta waves in leads 3 and AVF. Tall R in V2. V1, tall R in left-sided, but QS in right-sided tracts. ECG manifestations of right-sided bypass tracts. Both right free wall and right anteroseptal bypass tracts show left bundle branch block, LBBB, pattern in ECG, but differ in the QRS axis. In right free wall bypass tracts, the QRS axis ranges from 30 to -60 degrees. In right anteroseptal bypass it ranges from 30 to 120 degrees. Many complicated algorithms have been proposed, to conclude the anatomic locations of bypass tracts from the surface ECG, but here is a simplified algorithm. Step 1, tall R in V1 indicates a left-sided bypass tract, either left free wall or left inferoseptal. If QRS complex is positive in leads 3 and AVF, this is a left free wall bypass tract. If the QRS complex is negative in leads 3 and AVF, this is a left inferoseptal bypass tract. Step 2, QS pattern in V1 indicates a right-sided bypass tract. If the QRS complex is negative in lead 3 and AVF, this a right inferoseptal bypass tract. Left bundle branch block pattern with QRS axis from 30 to -60 degrees indicates a right free wall bypass tract. QRS axis from 30 to 120 degrees indicates a right anteroseptal bypass tract. Paradox. Left free wall bypass tracts, despite being the most common, they usually manifest lesser degrees of pre-excitation in ECG during sinus rhythm. Inferoseptal and right-sided bypass tracts, despite being less common, they usually manifest bigger degrees of pre-excitation in ECG during sinus rhythm. Clinical manifestations of Wolff-Parkinson-White syndrome, WPW. The WPW ECG pattern is uncommon and can be intermittent due to age-related degenerative changes and variations in autonomic tone. It disappears permanently over time in about half of the cases. WPW syndrome comprises the ECG pattern associated with tachyarrhythmia. Its prevalence among patients with WPW ECG pattern is about 2%. Incidence of arrhythmia is 1% patient years. Male to female ratio is 2 to 1. Most patients with atrioventricular bypass tracts do not have coexisting structural cardiac abnormalities. When congenital heart disease is present, it is more likely to be right-sided, mostly Epstein's anomaly, associated with right inferoseptal and right free wall bypass tracts. A familial form of WPW has infrequently been reported, and is usually inherited as an autosomal dominant trait. Clinical features of familial WPW. Patients present with syncope or palpitations, usually in the third decade. Pre-excitation on the ECG. Frequent paroxysmal supraventricular tachycardia and atrial fibrillation. 80% of patients above 50 years have chronic atrial fibrillation. Progressive conduction system disease is common by the fourth decade, such as advanced sinus node dysfunction, or complete atrioventricular block, with loss of ECG manifestations of pre-excitation. Progressive myocardial hypertrophy may occur. Premature sudden cardiac death occurs in 10% of patients. Gene mutations in familial WPW. PRKAG2 gene mutations were identified in these families. This gene codes for the gamma-2 regulatory subunit of the AMP-activated protein kinase. The described phenotype of this syndrome is similar to Pompe's disease. This syndrome thus probably belongs to the group of genetic metabolic cardiomyopathies. Arrhythmias in WPW syndrome. The most common arrhythmias are atrioventricular reentrant tachycardia, AVRT, and atrial fibrillation, AF. Symptoms include sudden onset and termination of rapid palpitations, chest pain, dyspnea, pre-syncope and, rarely, syncope. Symptoms are usually mild and short-lived, and terminate spontaneously, or with vagal maneuvers. Occasionally disabling symptoms occur, especially in the presence of structural heart disease. Atrial fibrillation, AF, in WPW syndrome. AF can be life-threatening, if the bypass tract has a short anterograde refractory period, resulting in very fast ventricular rates, with possible deterioration into ventricular fibrillation and sudden death. Drugs which primarily block the AV node, will encourage more conduction in the bypass tract, and transfer the very rapid atrial rate to the ventricles. These drugs, therefore, should be avoided during medical cardioversion of AF to sinus rhythm. Cardioversion of pre-excited AF. DC cardioversion should be used if hemodynamics are unstable. Medical cardioversion is approved if hemodynamics are stable. The approved drugs for AF medical cardioversion in patients with bypass tracts, pre-excited AF, include IV ibutylide and IV procainamide, Class 2A recommendation, and IV flecainide, Class 2B recommendation. These drugs depress bypass tract conduction. Amiodarone is no more recommended. All other antiarrhythmic drugs, intravenous or oral, mainly depress AV node conduction, and are contraindicated, because they can shift all conduction to the bypass tract, a condition known as full pre-excitation. These drugs include digoxin, adenosine, verapamil, diltiazem, beta blockers, Class 1A drugs, except procainamide, Class 1B drugs, Class 1C drugs, except flecainide, and Class 3 drugs, except ibutylide. Evaluation of WPW patients. 1. Initial evaluation, history, physical examination, and 12-lead ECG. 2. Event recorder, in patients with brief self-terminating episodes of palpitations. 3. Echocardiography is required to exclude structural heart disease. 4. Electrophysiological studies, EPS, are needed when non-invasive testing does not conclude that the bypass tract is a low-risk one, with a relatively long anterograde refractory period, that cannot conduct very rapid rates. Non-invasive low-risk features of bypass tracts. 1. In rest ECG, demonstration of intermittent pre-excitation on a beat-to-beat basis, abrupt change, not in serial ECG, is a low-risk feature. 2. In exercise ECG test, demonstration of a sudden loss, not gradual loss, of pre-excitation at a low heart rate, around 100 per minute, is a low-risk feature. However, the sensitivity of this test is poor. 3. In Holter 24-hour ECG monitoring, disappearance of pre-excitation with premature beats, or with paroxysmal atrial fibrillation, is a low-risk feature. 4. During spontaneous atrial fibrillation, a mean pre-excited RR interval greater than 250 millisecond, or a shortest pre-excited RR interval greater than 220 millisecond, is a low-risk feature. 5. During normal sinus rhythm, complete block of bypass tract and disappearance of pre-excitation with IV ajmalin, 1 mg per kg over 3 minutes, or procainamide, 10 mg per kg over 5 minutes, is a low-risk feature. 6. Transesophageal stimulation of the atrium, to measure the anterograde refractory period of the bypass tract, may also be used for risk stratification. Indications for stress testing in WPW. 1. To assess the bypass tract risk. 2. To reproduce a transient paroxysmal arrhythmia, and document the relationship of exercise to the onset of tachycardia. 3. To evaluate the efficacy of antiarrhythmic drug therapy. Electrophysiological studies, EPS. EPS may be used for 1. Evaluation of the bypass tract refractory period, atrial extrastimulation or atrial pacing, near to the bypass insertion site, is done to determine the maximum rate at which 1-to-1 conduction over the bypass tract occurs. 2. Induction of atrial fibrillation should be attempted, to determine the mean and the shortest RR interval during pre-excited atrial fibrillation. Indications for EPS in WPW. Inability of non-invasive testing to demonstrate low-risk features. Patients being evaluated for catheter or surgical ablation. Survivals of cardiac arrest. Family history of sudden cardiac death. Unexplained syncope. Symptomatic patients. Engagement in high-risk activities. Need for cardiac surgery for other reasons. Thank you.